السلام عليكم ورحمة الله. بسم الله والصلاة والسلام على رسول الله. Welcome to our third lecture in our radiology course. I am دكتورة نهاد المأمون, R4 Radiology Registrar, Sudan Medical Specialization Board, starting the chest radiology with the scenario that assume that you are the doctor covering a clinic and a patient came to you complaining of cough and fever. You request him some investigations including CBC and find that the neutrophils in complete blood count are high. Then you auscultate his chest and find some area of crepitation. Then you decide to order a chest x-ray for this patient. You brought your request sheet and started to decide what to write as a request. Here our request sheet, just start to write. Here you have to write the patient name, because to be sure or make sure of the identity of the patient age. Accordingly, if you are in a hospital or a facility that recommend you to write down the patient ID number or anything, you have to write it down. Then clinical history of your patient, that I have a 29-year-old patient who came with cough, okay, and on examination he had crepitations on left upper or right lower chest. Then you have to specify your request. I need to do him chest x-ray. If you wrote that, this is a real request for the chest x-ray, but you have to specify the views that you recommend, either anterior posterior or posterior anterior or lateral view. These are three options of the chest x-ray you need to do. Routinely we start with posterior anterior chest radiograph. Let's see why. Starting with answering the question, how is the standard chest x-ray taken? X-ray is taken while the patient is erect, standing upright, in posterior anterior projection. That means the X-ray beam, while it extends from the X-ray tube over here toward the patient posterior side, toward its anterior side. When we say posterior anterior projection, means that we are imaging the patient from his back to anterior, facing his chest with the film. Tube film distance is 180 or 6 feet between the tube and the film. This distance equal 180 centimeter or 6 feet. You ask the patient to have a full inspiration, inflate his chest so as to look at the chest x-ray while it is inflated. Okay, so in posterior anterior chest x-ray we have erect posture of the patient, posterior anterior projection, we will see later why, tube film distance 180 centimeter or 6 feet, and in fully inspiration situation. Posterior anterior erect chest x-ray, the standard view is a posterior anterior erect chest x-ray. All chest x-ray are taken posterior anterior erect unless otherwise stated. Unless you are the doctor wrote that I need a lateral chest x-ray. But at once we write chest x-ray, most probably it will be done in posterior anterior erect position. As a general rule, assume that a chest radiograph is taken posterior anterior erect unless it has the words AB or supine written on it. The patient stands upright facing the X-ray detector with their anterior chest wall pressed against it. The chest X-ray or the X-ray tube is placed approximately 6 feet behind the patient. So the X-ray passes through the patient in the posterior anterior direction. The patient is asked to take a deep breath and hold it during the X-ray to ensure there is adequate inspiration and no breathing movement, which could make image blur or image artifact. Here the X-ray tube, this is the patient, and the detector is the film adjacent to the patient chest. What are the reasons of performing chest X-ray in posterior anterior direction? The first, that accurate assessment of the cardiac size due to minimal magnification. The scapulae can be rotated out of the field away. Reasons for performing the radiograph erect are gas passes upward, pneumothorax, and free gas underneath the diaphragm are more easily diagnosed. Fluid passes downwards, pleural effusion is more easily to diagnose. We will come to this when we discuss the pathology cases. But upright position, fully inspiration, and the patient anterior side is adjacent to the film to avoid the magnification of the cardiac shadow or the heart or the mediastinal structures. We will assume that we have got a candle, which is الشمعة. While you put your finger between the candle and the wall, then the light come and take the shadow from your finger, make it bigger. In another situation, if this is the candle and you put your finger very close or too close to the candle, then the size will be more larger of your finger shadow. That's why we use this at the same as the idea that we minimize the distance between the patient chest and the film to avoid magnification. So how much your finger was closer to the wall, the little magnification is made. That's why we need to do so in case of chest X-ray so as to minimize the cardiac shadow by making the anterior chest of the patient adjacent close to the film. This takes us to see the difference between anteroposterior and posterior anterior chest X-rays. Here we have two radiographs. The first one, this one is anteroposterior radiograph, and the second one is posterior anterior chest radiograph. This is while the patient stands like this, his back to the X-ray tube and his face to the film. This is posterior anterior. Anterior posterior means that the beam comes through the anterior chest of the patient and cut it to its back. So we start with B or A according to the chest X-ray beam. First meet the patient. If it comes from his back, then it is posterior anterior. If the X-ray beam comes from his anterior, this is AB chest radiograph. Let's see the differences between the two. In anteroposterior radiograph, we can see that the heart is more big than in posterior anterior radiograph, the first thing. Then the clavicles, this is the clavicles in either sides, seen above the apex of lung field in anteroposterior view, but in posterior anterior seen over the lung field. This is the next difference. The third difference, that the inner borders of scapula in anteroposterior radiograph, because the patient put in his hands like this in his sides, then this is the shadow of the triangular scapula posteriorly. But in AB, the patient can make his hands away from the X-ray beam, so the scapula get outside the field of the image. Again, this is BA and this is AB radiographs. The next difference are the ribs. We move this. The ribs in the anteroposterior, we have in the patient anteriorly, we have anterior ribs. Same rib curve posteriorly to give the posterior rib. So this is anterior rib and this is posterior rib. In AB radiograph, the visualized linear ribs are the anterior ribs. And in BA radiograph, the visualized anterior ribs are the posterior ribs, because we are imaging the patient from his back. So while we are reading posterior anterior chest X-ray, if we have a fracture over here in this point, we have to count the fracture, the rib number, first rib, second rib, assume this is the seventh rib. But is this the anterior or posterior? Since it is posterior anterior image, the anterior part of the rib and the posterior part of the rib over here. Okay, regarding this is the X-ray tube. The more magnified structure, if we put here a structure with a red color and a yellow color, and here we have our film over here. In the resulting image, the red structure, okay, let me draw it again, excuse me. Here the film, here the X-ray tube, here the beam. I have two structures, a red one and the yellow one. Okay, here the red one is far away from the film, so in the resultant image the red one will be magnified more than the yellow one, which is near to the film. This is the yellow one will appear like this as its size, but the red one will appear larger than its actual size. Okay, let's apply this for the patient. Here we have the patient and his back in posterior anterior is far away, so the posterior ribs are in red color, and here the anterior ribs are in red color, and here let we make a marker, the posterior rib in red, here the anterior rib with red, but in yellow color the anterior rib in posterior anterior. Okay, and here the anterior ribs, the posterior rib, sorry, in posterior anterior. So that means Every structure in yellow color is better in each image. The yellow is the best because less magnification, almost the same size, and less or not like the red one which is magnified. So in PA chest radiograph, this is the PA chest radiograph. The yellow one is the anterior ribs. Okay, these are the anterior ribs because its size almost equal to the original size. This is the anterior ribs in PA chest radiograph. And in AP chest radiograph, the yellow one, this one, this is AB chest radiograph. The yellow one are the posterior ribs. This is important because of when you are specifying a fracture in a certain rib, when you are reading a posterior anterior chest X-ray, if the fracture is here, then it is a fracture in an anterior rib. If it is a P radiograph and the fracture is here, it is a posterior rib. Okay, so the ribs are the end number, okay, or letter, sorry. In PA, the clear visualized ribs in anterior posterior view here, okay, the anterior posterior, the posterior ribs is better visualized, so this is wrong. And in PA radiograph, the anterior ribs are better visible. Okay, this is wrong in this context. The last point, that in anterior posterior view, the magnification of the cardiac shadow may appear as cardiomegaly. Okay, we can assume if we remove the markers, deleted the AB and posterior anterior view, and we give you only the two X-rays. At once you saw this image, you can say that there is cardiomegaly in this one and no cardiomegaly in this one. But actually this is false cardiomegaly because of the position of the patient. In anterior posterior view, the heart is magnified. Back to the first point, that the clavicles in the posterior anterior are here, which is appear over the lung field because it is behind the lung field, but over here it appear anterior, so above the lung field. Okay, in AB radiograph. That is all regarding the differences between anterior posterior and posterior anterior chest radiographs. Let us now move to a quiz. You have 15 seconds to specify which one is AB and which one is PA chest radiograph. Time's up. Now to the answers. Here we have the cardiac configuration smaller than this one. Another thing that they wrote down, supine mobile radiograph, which done for patient in for example ICU patient who can't move to the X-ray room. Okay, then we can do him supine mobile chest X-ray. So this is the posterior anterior chest radiograph and this is the anterior posterior chest radiograph, because the magnification of the cardiac shadow. PA chest radiograph and line diaphragm, AP chest radiograph and line diaphragm. Diagram, sorry. The other difference also in the inspiration, while the patient stand up, the maximum field of the lung is expanded, but less in supine or AP chest radiograph. Another difference between the two. Now move to the next. So here we have finished the PA erect chest X-ray. Then let's move to the other views. AB anterior-posterior or supine chest X-ray is performed when the patient is too ill to stand, like in intensive care unit, ICU, or emergency department resuscitation, the resus room. The X-ray tube is placed in front of the patient and the X-ray pass in the anterior-posterior direction. The major disadvantage of AB supine radiograph when compared with PA radiograph is that the mediastinum and cardiac size will appear wider due to venous distension and magnification. Therefore, you shouldn't comment on the cardiac or mediastinal enlargement on an AP supine radiograph. Another view, the lateral chest X-ray. Let's see a diagram or the position of the patient in lateral chest X-ray first, then come back to the text. Here, a lateral chest radiograph diagram. The patient is stand in his side to the X-ray tube and his other side to the film. And his hands or arms is away up, because if he put his hands on each side, it can obscure the lung fields bilaterally. So this is a lateral chest radiograph. The normal chest radiograph can visualize the lung fields with the heart in between and the mediastinum. This is the bone of sternum and manubrium sterni above it. Also, we have the thoracic spine posteriorly. A normal sign that because the lung is triangular in shape and small here above and large or wide below, then the ossification of the vertebral column posteriorly is whiter above and more darker below. This is a normal sign. It calls more dense sign. If we have any pathology or fluid or process going over here, will obscure the lower spine of the chest, okay, or thoracic spine. This is the lateral chest X-ray. Back to the text. Lateral chest X-ray is an X-ray taken from the side of the patient and may be used to give further views of the lung and heart, and more detail on the anatomical location of lesions. It is rarely performed nowadays, as almost all lesions on lateral radiograph can also be seen on frontal radiograph, either it's PA or AB radiograph or supine. And if more information on the location of the lesion is required, then a CT scan of the chest is more precise. For these reasons, we have decided not to cover lateral radiograph. That's why we have used another resource to complete the lateral chest radiograph details. You are the doctor covering a clinic. A mother of a child brought her child to you and said that, oh doctor, my child had coughed suddenly. I don't know what happened. Then you request to the patient a chest X-ray. You find this image like this. Since the 5 densities that we have reviewed before, the first density is air, which is black. Second is the fat, like subcutaneous over here. Then the third is soft tissue, like the muscles of the chest wall. And the fourth was the rib or the bone density, and the fifth was metallic, which is more denser than any one of the 5 densities. So since you saw this image, you decide that there is a foreign body, okay, looks like a coin within the chest of this child. But in this area, anatomically, you have the trachea and the esophagus also overlapped each other. And you have to decide now either to refer this patient for endoscopic removal, either in chest or pulmonology department or the upper GI department. You need to request a lateral chest radiograph to specify whether this coin situated in the trachea or the esophagus. And we move to the lateral chest radiograph, which appear clearly that the coin is situated anteriorly. 15 months old child, suddenly red in face and shortness of breath. And another image of a 4-year-old child with choking episode. We move then to lateral radiograph to specify the position of the foreign body. This all regarding lateral chest X-ray. Moving to how to measure the heart size or the cardiac size in a chest radiograph. We can use the ruler in back system, which is if it is in computer system, to measure the diameter of the thoracic cavity, and then measure the cardiac contour. This should be not more than 50%. If it is less than 50%, we are within the normal. If it is more than 50%, then there is cardiomegaly. This is called cardiothoracic ratio. Cardiothoracic ratio shouldn't be more than 50%. And we measure this in posterior-anterior radiograph. Moving to adequacy of quality in chest radiograph. When to say the image is good quality or poor quality chest radiograph. We have 3 components to specify the main quality of the chest X-ray. The first is the penetration, inspiration, and rotation. Added to it, magnification and angulation. Penetration means that how much the X-ray beam had invaded the chest radiograph or patient chest. If the chest X-ray was very strong, we have this image which is over penetrated, a very strong beam. Adequate beam give a normal chest X-ray with a good quality. If the chest X-ray done with the beam very weak, then we can't visualize the differences between the structure well. It is then under penetrated. So the penetration or exposure in chest radiograph depend on the quality of the beam used. It should be suitable for each part of the body. There is multiple parameters that specify that the kV means the energy set in the chest X-ray tube okay. kV, which is kilovoltage, means like electricity. ده ملي أمبير أو فرق الجهد، اللي هي كلها واحدة من العوامل بتاعة ال chest X-ray tube. And even the exposure time. Any one of these, if increased, then can result in over-penetrated image or adequate image or under-penetrated image. Over-penetrated بنسميه إنه يعني حرقنا الفيلم because we can't see these details here. The right way or the best image like this, we can visualize the lung field and ribs and the mediastinal contour. Here we can specify if this is true pathology or this is only from the quality of the beam or the penetration of the beam. Why it is important to monitor the exposure or penetration? Because sometimes it can mimic a pathology. If you are the doctor in the clinic and the patient, you request your patient a chest X-ray and he bring this with him without this is written in the image, you might refer the patient to chest physician for follow-up of the underlying condition. There is opacification bilaterally of this chest X-ray, so it can misunderstand it or mistook like underlying pathology, while the patient actually this is the image of the same patient normal with adequate exposure. That's why you are a doctor should know the parameters for the adequate chest X-ray. The next is inspiration. In inspiration, we use counting of the rib as a parameter to assess the inspiration of the image. Like here, before I take the exam, I told my patient to hold a breath. Then the resultant image should be from 8 to 10 ribs appearing. Okay, from 8 to 10 ribs should appear in this image. So then I can say that this image is well inspirated. Okay, if it is less than that, then isn't fully inspirated. Adequate inspiration, the posterior ribs are numbered in this photograph. 10 posterior ribs are visible above the right hemidiaphragm, an excellent inspiration. In most hospitalized patients, 8 to 9 visible posterior ribs seen in the frontal projection is an inspiration. In an inspiration that is adequate for accurate interpretation of the image. When counting ribs, make sure you do not miss counting the second posterior rib, which frequently overlap the first rib. Okay, let's maximize this image. Here we have the first rib, looks like this. This is the second rib, the third rib, the fourth rib, which is always posterior to the clavicle, the fifth rib, the sixth, the seventh, till to the 10th rib. This is regarding the inspiration. Moving back to the rotation. Rotation means the clavicle of the patient. If the patient is rotated while he is standing in front of the film, rotation spinous process should fall equidistant between the medial ends of the clavicle. That means in this image the clavicles end here and the other clavicle here. This is the normal. In rotated patient, you can find here the spinous process. This is the spinous process of the thoracic vertebra. Okay, you can find the spinous process over here, and this clavicle near and the other one is far away from it. So these distances can assess the angulation of the patient. طيب معنى الكلام ده in simple words in Arabic إنه البيشن وهو ظهره مع الفيلم وأنا بصوره بس في مسافة between this side، يعني البيشن ما واقف completely، لا، في one of his sides is far away from the tube. Like here, this is the film and the patient with his right side adjacent and the other side is far away. There is a distance in that way, not like this. طيب بعبر عنها بالangulation. Okay, that means the angle, the patient is angled. While we speak about spinous processes, we mean the spinous process of the thoracic vertebra because it is a central structure in between. Then we move to the other factor which have been discussed before, the magnification. Magnification, anterior-posterior films, mostly portable chest radiograph, where will be magnify the heart slightly. The heart is magnified in anterior radiographs, as we've seen before, like this. Okay, here the anterior posterior, the heart is magnified, unlike the posterior anterior films. Okay, so the rotation and angulation are in same area. That rotation, the spinous process should be in the center between the two clavicles, and even the clavicles should superimpose the third and fourth rib, like this image here. So the fourth rib and the third rib are underneath the clavicle bilaterally, and the spinous process of the thoracic vertebra in the center, equidistance between the two clavicles. This all regarding the technically adequate chest radiograph definition. Now time for a slide quiz regarding this image. Please specify the type of radiograph. Is it AB or BA? And specify the adequacy parameters. Is it underexposed, overexposed, or adequately exposed? 10 seconds to answer. Time's up. Okay, this is, you are right, this is anterior posterior radiograph because of the cardiac contour is very large and the inspiration is diminished. The second one, yes, you are right, it is underexposed because we can specify the line of the spine posterior to the cardiac contour or cardiac shadow. So this is a B radiograph, okay, under exposed. Regarding its quality, it look like this image over here. We will see the spine posteriorly inadequate, overexposed, even the detailed spine is appear, and here the underpenetrated, which is we can't appreciate the spine. So this is underpenetrated image. Another question regarding this image. Count the cardiothoracic ratio in this image. What do you think? Okay, it looks like that because of the magnification, then the cardiac contour is almost more than 50%. So there is cardiomegaly. Unfortunately, this is anterior or a AB radiograph, which is not the suitable radiograph to assess the cardiothoracic ratio, but you are right, it visualized as cardiomegaly because of the cardiothoracic ratio is more than 50% in this image. So this patient might have cardiac failure because of the enlarged size of the heart. Moving to the next, comment on this penetration of this radiograph. 5 seconds, because things getting easier. Here, this is over penetrated. Okay, over penetrated because زي ما قلنا الصورة كأنها محروقة because الbeam is very hard and I can't visualize this structure over here. This is over penetrated radiograph. Let's see some diagrams to assess the quality. Here we have the rotation parameter that the spinous processes are in equidistance between the two clavicles in between. Here an image of a rotated patient while imaged because the spinous process in a direction and the two clavicle in a direction, so the patient is rotated. Regarding the adequate inspiration, we said that we have to count the reps. 8 to 10 reps in the lung field should be apparent, like in this image. This is normal radiograph. Here less inspirated or inadequate inspiration because we have only 4 ribs above the diaphragm appear in the radiograph. This is all regarding the technical parameters. There is another view that calls lateral decubitus film. If we have patient who has fluid within the thoracic cavity, as you know, always the fluid is situated in the depending area. You can do the lateral decubitus to see if the fluid can move to the dependent side or not. This is a lateral decubitus film. This is all for today, and next time we can review some anatomy and pathology of the chest radiology. That is all. Good luck. Thanks for your attention. Good luck.